And tonight we're going to be talking about a very important subject called Essentials in Palliative Care. Thank you for coming. I know Friday night is a busy time, especially this time of year. We had Halloween last night, Diwali is tonight. And I always appreciate when people can drop in as long as they can with our busy lifestyles. Good. So I wanted to go through some of the palliative care information for you. And this is a little course I kind of put together to help people looking after their loved ones or children. I kind of did it for people that are maybe looking after their parents inside of their home. It could be other relatives as well. There's a lot more extended families in Canada, parents, aunts, uncles, those types of relatives. And then maybe they don't have any information about healthcare, right? They never wanted to be a nurse, they never wanted to be a PSW, but now they find themselves looking after a loved one, and that loved one is nearing the end of their life. And so that's why I kind of put this course together for that reason. And in looking after someone at the end of their lives, we kind of have a term for that called palliative care. And sometimes people go to a specific building to have that care provided for them, which we call a hospice. So, palliative care and hospice, they do have a history. Hospices probably started way back when nuns used to look after people inside of their homes, or even during dramatic times in history like the Black Plague or leprosy. Sometimes people would kind of be removed from little towns and put in special areas around the town. And then volunteers like nuns and whatnot would provide care to them at the end of their lives. Nowadays, the more modern concept of palliative care came about in the 1960s. And I think London, England always likes to take credit for that. And let's see here if we can keep this going. Yep. And I like this quote here to start things off. It's not being dead, but the dying that people fear. So it's not so much when people die, it's what they have to go through to get to that point of death, right? So they're talking about things like pain or some of the signs and symptoms that we're going to be talking about tonight uh, are included in some of the fears that people have, right? So palliative care has kind of been initiated by doctors as well. In the 60s, doctors realized people could actually live longer if we kind of had a method or organized method of healthcare to look after their needs. It used to be just physical, right? Keep them comfortable, keep them for as long as they could hold out for until they passed away. Nowadays, we look at all aspects of a person's character and life. We call that more of like a holistic approach. And we're looking after the person's physical self, mental self, emotional self, spiritual self. They're all kind of connected together. And let's see here. Yeah, like so. Okie dokie, we are back and we are going to get into palliative care now and learn what we can. So, palliative care or hospice palliative care is more of a term that we use for our approach to care. So, how we actually approach someone that is in nearing the end of their lives. Palliative care usually means 6 months left to live or less. Usually, a doctor will diagnose a client, family member, give you the news of how long he thinks they have left to live, and he'll kind of do an order or classify them as palliative care. But palliative care isn't just the physical care that we provide, it's more of an approach or more of an attitude. And some of the characteristics of hospice palliative care is that it recognizes dying as a normal process. So, like, it recognizes the decline of your loved one or client. It confirms that the dying person and their family members are should be looked after and cared for. So, it's more about the family unit. And we do provide that care in a holistic way, keeping in mind our dimensions of health that we mentioned earlier. And we also want to provide preventative techniques or early detection of symptoms so we can provide the highest quality of care possible to our clients when they are in decline. Now, terms that are kind of used with palliative care, such as end of life care, chronic illnesses, holistic care. End of life care is a general term that we use for our loved ones when they're nearing the end of their lives. Holistic care is more the holistic approach, looking after all of our clients or loved ones' needs. Hospice is the building that they would go to. Hospices are very interesting because the care they provide is very focused, very client centered. Like, hospices are usually a building out in the community, like a house, and then inside of that home, you're going to have like a doctor, a nurse, PSWs. And usually there's only two or three patients or family members at the end of their lives. So it's very concentrated and focused. That's why some people pick hospices over other places nearing the end of their lives for those types of reasons. Okay, so what is this palliative approach that we're kind of talking about? In a physiological way, we're kind of talking about integrating not only our clients or loved ones' diagnosis, but also how we're going to approach or kind of integrate the quality care that we want to give them. We want to kind of start some of these preventative techniques as early as possible. So palliative care is 6 months left to live or less, but sometimes we want to have these preventative treatments start right away. So if I use nursing homes as an example, residents that move into a nursing home, the average lifespan after they move in is 18 months. So if they live there for a year and then they go palliative care for the last 6 months, the philosophy is, why didn't we start that when they first came into the nursing home? Why didn't we start some of these preventative measures or even curative techniques? Like, yes, maybe they have cancer, maybe it's stage 4 cancer, and then is it going to be helpful to do different types of therapy like radiation therapy, chemotherapy? Those types of therapies should be still instituted. So you're kind of using curative techniques to provide the highest quality of life possible. Like, you don't give up on any positive techniques that are working for your client or loved one. You want them to have that highest quality of life while they're still in decline, right? So these types of terms mean different things to different people, but the term palliative care is the one that we use in healthcare and the one that means the client is nearing the end of their life through decline. So as our loved one is approaching death or our clients are approaching death, using the term appropriate or appropriate death is something we should keep in mind. So appropriate death just means what kind of care or what kind of circumstances does your client or loved one want when they're approaching death? So it's kind of like trying to analyze and figure out their likes, their dislikes, how they want to proceed when they're in decline. What do they want to happen when they're in their final weeks, final days, final hours? And I've even had clients that do their own funeral. They actually organize their own funeral when they're in decline, and they say, "This is the music I want. This is who I want to be there. This is who I don't want to be there at my funeral." So they kind of go through that type of thing and organization. So, appropriate death is when we provide our client with their needs and desires. We're not just thinking about our own selves or healthcare rules. We want to kind of provide these, what we call personal preferences that our client would actually want for themselves, and trying to give them the most appropriate death possible, right? One of the things clients usually say is pain free. They want to decline and get to death's door pain free. So, we're going to talk a little bit about pain medication and other ways we can help our loved ones or clients try to stay pain free as possible during their decline to death, right? Now, one of the diseases that is becoming more and more common in Canada is called dementia. Dementia can be a very puzzling disorder for your loved one or your client to have. The word dementia just means brain loss or progressive brain loss. Dementia is considered what we call a syndrome. So a syndrome just means there's all these other different symptoms that are making up that dementia. Okay. Because sometimes it can be confusing when you think about dementia, Alzheimer's disease, Parkinson's disease, Lewy body disease. Sometimes it kind of causes confusion when the doctor says they have dementia and Alzheimer's. What does he mean? Dementia is just like the headline or the syndrome, kind of like an umbrella effect. And then all the symptoms that make up dementia are these other diseases. Okay. So Alzheimer's disease is by far the number one symptom, which is a disease that makes up dementia. Alzheimer's is about 64% of dementia is caused from Alzheimer's disease. Alzheimer's disease is a disease that is kind of making the neurons in your brain not operate or function anymore. The electrons and the communication between the neurons in our brain start to shut down. And this causes your client's thinking to be distorted. And usually it's going to be things like memory loss or bad decisions, poor judgments. We're going to go through some of those in a second. But those are some of the characteristics of Alzheimer's disease. And because it makes up so much of dementia, it's very similar signs and symptoms, Alzheimer's disease and dementia. Vascular dementia is when your client or loved one is having what we call TIAs, transient ischemic attacks. Some people call them small strokes or mini strokes. The blood kind of gets clot in a brain artery for a few seconds, and then the blood starts flowing again. That's kind of what vascular dementia is. And then they have many of these small strokes. So every time they have a small stroke, it kind of chips away at their brain function. It shuts down those neurons in their brain, causing dementia in your client or loved one. Okay, so those little tiny strokes are actually causing multiple damages to your client's brain cells when they're having them. So another popular dementia is Lewy body dementia. This one is very similar to Parkinson's disease. It kind of has a buildup of proteins in the brain, and when the brain gets overwhelmed with these little proteins, it affects communications in the neurons, actually making them shut down. Neurons do not regenerate. like the cells of our body regenerate, but the little brain cells, the neurons do not. So that's why your client is going to be suffering from cognitive impairment with these types of dementia, right? So Lewy body is one. Another one is Pick's disease. Pick's disease is the same as frontal temporal dementia. And if you know who Bruce Willis is, that's what he has. He came out recently and said he had frontal temporal dementia. It affects the front part of the brain cells, kind of affects the client's communicating abilities, kind of affects his mood, kind of can make him more, how you say, outlandish, maybe cursing, swearing, those types of things could occur with frontal temporal dementia. Like there's no filters when you get this disease. And Pick's disease is a huge part of that. And then the last one here, Gertzfeld-Jacob disease. I'm sure you've heard of mad cow. This is the same as mad cow disease. This has to do with eating tainted meat or tainted cow meat, for example. And that really causes serious effects in the brain. It's very deadly. It will kill someone within 12 months, 12-month sentence if they get diagnosed with Creutzfeldt-Jakob disease. And everybody has heard of different types of meat boycotts. Canada had a meat boycott from other countries. Other countries were not buying meat from Canada because they found mad cow disease in one of the cows. So, a very serious situation if that gets diagnosed in your client or loved one. So, we're looking at some of the signs and symptoms now for dementia that you should be looking out for. I think the most common ones are memory loss. You're going to notice memory loss in your loved one or client. Also, repeating words, repeating sentences seems to be another one of those popular signs and symptoms for dementia. Any one of these you could list as signs and symptoms for dementia: forgetting simple words, confusion, getting lost in familiar places. You start to notice they have poor judgment, decreased judgment, apathy. They don't want to do anything when they wake up. They're more apathetic, loss of interest in life. And dementia is kind of characterized by three different stages: stage 1, stage 2, and stage 3. You could say mild stage, moderate stage, and severe stage. So the stages just means those signs and symptoms we just looked at are getting worse and worse and worse as you go through each three of these stages. So the more it affects the brain, the more severe those signs and symptoms are going to be. Dementia or dying with dementia can take many years. It can actually take decades. It can take up to 20, 25 years from diagnosis to actually die from dementia. So a very long, arduous journey, not only your loved one or client has to go through, but also family members too, right? Family members have to take this journey with their loved ones, so they're going through the stages as well. Dying with dementia is very confusing, very puzzling, very confusing, because sometimes it looks like the client is actually getting better. Like the doctor will say he's starting to improve a bit, but then he declines, he improves, and he kind of goes up and down like a roller coaster. Some people call it stuttering dementia, because it looks like a zigzag going up and down, where he has relapses of getting better and then decline. So that's why it's so puzzling, because the client is wondering himself if this is going to be the last time he's declining to death. Family members are wondering themselves if this is going to be the last decline until death as well, right? Now, people with dementia can still live on their own in stage 1. Stage 1 is more of the mild signs and symptoms. Stage 2 is when it gets more serious, maybe so their memory loss increases, sorry. They also forget things more. They also making poor judgments. Maybe they're going to leave the oven on. These types of things start occurring in stage 2. Stage 2 is usually when a family member steps in and the client or loved one is going to need extra assistance. So whether that's going to be home care for stage 2, or they're going to look at retirement homes or nursing homes, those types of decisions are usually kind of worked out in stage 2 of dementia, because when they get to stage 3, it's very severe, right? Severe symptoms. They start to not recognize family members anymore. They think they look 25, 30 years old. And then when they look in the mirror, it could be traumatic or shocking to them, because the mind is playing all these tricks on them, right? The cognitive decline is increasing into the severe stage. Their central nervous system is starting to shut down, so they can actually have seizures as well because of that. And so it's very uncertain when death will occur, but it is certain that it will occur, right? Like a doctor will tell you, dying with dementia, yes, death is certain to occur. It's just the timing. It's the timing and what it looks like. The trajectory can be very slow, like I said, many, many years. It can also look like a zigzag up and down, what we call stuttering trajectory. How the client's health is in other areas of their life, which we call comorbidities. So other healthcare problems could affect a decline. And usually, dying with dementia, interventions aren't going to help very much. Interventions are like a G tube for feeding, or oxygen therapy, or these types of things. Usually, because death is certain to occur, it's just a matter of timing and how the trajectory is going to look for your client. Okay, so one of the other things you have to look out for with dementia or other types of illnesses during the palliative care process is your client will have periods of difficulty breathing. Again, this depends on comorbidities. Like, did they smoke during their life? Do they have other respiratory illnesses? COVID was a very good one for difficulty breathing, right? So the medical term for difficulty breathing is dyspnea. Dyspnea just means your client is having breathlessness. So, as caregivers, we want to make sure we're kind of providing the best environment or atmosphere for our clients. And sometimes it might be something simple like opening a window, putting a fan on in their room. Positioning of the client is very important. They might breathe better when they're kind of more in an upright position, what we call Fowler's position in the healthcare field. And usually medications will be given for this type of breathlessness as well. So the other thing along with breathlessness is pain. So the number one and number two signs and symptoms you're looking out for are breathlessness and pain. Pain happens to be the number one feared symptom in the dying process, right? If you think about it, most of us do not want to go through severe pain as we're approaching death. So, pain is something we want to manage for our client, our loved one. We want to make sure they're as pain free as possible, right? Which we call pain management. So, pain is a whole person experience. It affects them physically, mentally, socially. They don't want to have visitors. They don't want to go out anywhere. They don't want to see anybody. It affects them in a holistic manner. We want to keep that in mind. So if your client is experiencing pain on his decline, there's definitely going to be medications in use, which we call pharmacological avenues. Pharmacological or pharmacy medication is something that will be part of your client or loved one's routine. So with pharmacological, we're trying to set up the medications to prevent those symptoms, to prevent the breathlessness, especially to prevent pain. So like it says here, we're trying to use anticipation because it's much easier to anticipate when they're going to have pain and when to stop that pain through medication. So what the doctors usually do is they kind of do a cycle of medication over a 24-hour period. Healthcare workers, family members are kind of communicating with the doctor if their loved one or client is still having pain. And then the doctor can increase or decrease the pain as needed. And they can also give extra doses of pain medication as needed. The doctor is very careful with the milligrams of the medication that he's providing, obviously, and they want to anticipate the pain so they can kind of take care of it before your client experiences the pain. So, also with opioids, they can also be used for breathlessness as well because they work on the receptors in the brain. Receptors in the brain cause us to feel pain. So, that's what opioids do. They kind of mask those receptors, decreasing our pain threshold, right? And also with breathlessness, sometimes they can work on the medulla part of the brain that controls our breathing and kind of help your client if they're having breathlessness as well. So opioids can be used for that dual purpose and other signs and symptoms as well, right? That your client may have to take medication for because they're taking opioids for pain. Maybe they're going to need medication now for constipation or other signs and symptoms that they're having, that type of thing. Okay, so if the client can still take medication through their mouth, which we call orally, that's what they're going to go with first because that's the easiest. But as your loved one or client declines, that might change, right? They're no longer able to take it in their mouth. They have problems swallowing. They might try to crush the medication and mix it with pudding first. If that doesn't work, they're going to go to another route to get medications into the body. So that could be injections, or it could be like a little needle they actually set up on the person's thigh area, and then the family member or the nurse will kind of inject the medication into the little needle that's connected to the client's thigh, so it goes right into their bloodstream. That's popular while the client is declining in the final weeks, right? Because they might need these opioids 4, 5, 6 times a day. So they kind of set up the little syringe needle in the client first, and then you just come along with the syringe and inject the pain medication that way. Much easier and much more efficient as well if they do it that way. So family members as well as other people do have a lot of fears around opioids. Obviously, there's the addiction factor. They're always asking about addiction, questions around that. Dependency, will it affect their breathing? Opioids do tend to lower the respiratory rate in a person. The doctor is very specific though with the milligrams and when they're given. Like doctors aren't going to get them too close. Like they're still far away from the amount of milligrams they would have to take for anything fatal to happen. And medication and doctors these days are very specific, very good with the dosage and how many times a day that they're going to be getting it. So that is kind of handling itself right now in the healthcare field with the more precise techniques of administering medications. Okay, so they're kind of saying some of the other things that could occur taking medications, confusion, sleepiness, these types of things. If family members are visiting, it's kind of a good idea to figure out when they're getting medications. Like if you're giving a loved one medications, do they have other people visiting? So you're gonna kind of hold off until the visitors come. Obviously, you want your loved one or client awake and alert for those types of visits when they're declining. And also for healthcare workers, they should make sure the client gets their medications before they have to go in, wash up the person or turn them over, those types of procedures. They should make sure the pain medications are taking effect first. Most pain medications are take about 20 minutes, so 20 to 30 minutes for them to get into the bloodstream and start taking effect on the client. And so here, like I was saying, there's other symptoms that could occur just because they're taking pain medications. We call them opioids because they do come from the opium plant. And so opioids are the medications most given for pain. And you can see these other signs and symptoms, right? Nausea, vomiting, constipation, confusion, delirium, drowsiness, those types of things we're looking out for and kind of taking it as we see them, communicating with the doctor and letting them know what's occurring, right? If you're first kind of looking out for signs of pain, you should be looking out for these types of things like facial expressions, pain facial expressions, very easy to recognize. You do care on the person and they start moaning or groaning and having that facial expression. You're looking out for those types of verbalizations as well as nonverbal behavior. Nonverbal behavior is important as well, or any changes in mental status could be due to pain. Obviously, changes in behavior, like they're not doing any activities anymore, could be indicators of pain in your client. And so, obviously, we want to provide as much comfort measures as possible. So, we've talked about medications, which we call pharmacological. The opposite of pharmacological is non pharmacological. So, we always want to apply non-pharmacological methods for our client as well. So what is their positioning? Can we promote more comfort, relaxation, safety to our clients through the position that they're in? And again, they're kind of mentioning always observe for pain. Any type of mobility aids that could be helpful for the client. If they are still getting out of bed and they are mobile, mobility aids, walkers, those types of things could be part of the care you want to look into. If they are in bed, they're declining, approaching palliative care. So, comfort measures are very important in this instance. You can even do things like breathing exercises with the client. You breathe in through your nose, breathe out through your mouth, get them to do it along with you. Fresh air is good. Make sure you're not the problem. Cologne, perfume, that type of thing. And kind of trying to create the best comfort possible for your clients. If you are aware of any alternative therapies, like massage therapy is always good. Healing touch therapies are always good. Music plays a huge role as well in comfort to the clients. That goes along with the appropriate depth we were talking about earlier. You should know your loved ones or your client's favorite music and have that playing gently in the room for them. That's a good one. And kind of common signs and symptoms when the client is declining. One of them is anorexia and cachexia. So obviously, the amount of food and fluids that they're taking in will change, and they will decline, decline, decline until nothing. Then maybe they're going to have fluid still, decline, decline, decline until nothing. So that's very common with palliative care. Your loved one or client's intake of food and fluids will decline down to nothing. So this is going to cause other signs and symptoms, right? Dehydration. So think about no fluids getting to the brain. That can cause delirium, difficulty breathing, definitely fatigue, definitely sore mouth, nausea, vomiting, those types of things. When the body starts to shut down from palliative care, it shuts down from the outside in because it's trying to protect all of the vital organs inside of the body. So that's why the outside skin will kind of go cool. If you touch it, it'll be cool or cold because the body is protecting the vital organs inside of itself as the decline approaches, right? Okay, so sometimes when our loved one or client is approaching palliative care, we want to have those conversations around the dying process. Very difficult to have, but very important, right? To provide that appropriate death we talked about, or any other personal plans that your loved one or client will have. You want to have those conversations before it's too late, right? And when we kind of organize end of life care like that, we call that advanced care planning. Advanced care planning is looking ahead to when palliative care approaches and what your loved one or client really wants. And you're kind of working out after death what your client wants, or funeral home, like I said earlier, funeral themselves, those types of things. Another thing, So another thing that is becoming more and more popular in Canada is medical assistance in dying. I'm sure you've heard of this one, MAID. MAID is very popular. It started in Canada in 2017. MAID just means your loved one or client is having a conversation with you about the end of their lives. And basically, they want to choose, they want to have the right to choose when they want to die. So they can kind of do like an application form with the Canadian government. Now, there are rules and stipulations around that. You have to be seen by a doctor. You have to have illness or disease. They're kind of tweaking it a bit right now, whether it has to be a terminal disease or not. There's obviously a lot of controversy around this, right? Because Canadian government is looking into including people with mental health disorders being able to get MAID. So there's a lot of controversy around that, whether they should be able to make that decision for themselves if they do have some type of cognitive impairment or even mental illness, like they're including depression, bipolar disease. Should they be allowed to make decisions about the end of their life as well? The government hasn't officially passed that yet, but for now, it kind of goes through a process where your loved one or client would have to be seen by one or two doctors actually, and kind of be determined to be able to make that decision on their own while they're doing the application. The application goes to Ottawa. They get approved for MAID. Once they're approved for MAID, then they can keep that in their back pocket. They don't have to do it right away. They can kind of just get approved, and then maybe they're not going to do it, right? Some people just get approved for MAID, and then they say, okay, if I want to do that, I will, because you don't have to set a date after you're approved. They can kind of keep it and see how things go from there. So that's medical assistance in dying, and there's going to be a lot more coming out from the government on that within the next year or two. Now, very difficult period of time is after a client or a loved one passes away. Things that we should keep in mind, right? Loss and grief are normal. So, talking about loss and grief, it is normal, it is natural. Declining health, usually your loved one or client is suffering from multiple losses. If you think about someone with dementia, right? All of the things that they used to do in their lives, they start forgetting how to do those things little by little. So almost on a daily basis, they're suffering losses. They forget how to read, they forget how to write, they forget how to use a cell phone, they forget people's names. All these little losses are creating these little traumatic effects in your loved one or client. It's almost like dying from a thousand cuts, right? You're suffering this decline as you go through this process of dying through the dementia that we talked about. So, obviously, after death, we're going to be suffering from some type of loss and grief. People do grieve differently. Everybody kind of grieves differently. Some people are more stoic until they're alone, and some people like to have an openness right away. So different people are going to grieve differently. It doesn't mean they care more or less for the lost loved one. It just means everybody has their own way of dealing with loss and grief, and they're going to handle it in their own way, right? So then, loss and grief, kind of, you have to be aware, self awareness, check yourself. Do you need extra support, extra help, extra mental health therapy for yourself or other family members? That type of thing would be important after death, and trying to look after yourself as well. So, in the final hours, we're kind of looking at these final signs and symptoms that your client or loved one might have. How do you know they're only maybe a few days away from death or a few hours away from death? I think the color of the skin, so skin color change, is probably number one, because the oxygen isn't circulating around the body like it used to. So usually this tends to show up as bluish color to your client's skin or your loved one's skin. And it usually starts at the feet. So it usually starts at the toes where you notice a bluish color. then the feet, then the ankles, and it kind of works its way up the legs, approaching death. So it's kind of like you can look at their lower legs and feet and kind of discover how long, or an educated guess of how long they have left to live. Even the nails, like their fingernails, start to turn blue. The medical term for that is cyanosis. It just means a lack of oxygen getting out to those cells of the body. But I mentioned earlier, the central nervous system starts to shut down during decline. So they're going to get different types of twitching that might be occurring in them, rapid movements, restless legs. These types of things are common. Delirium is very common, right? Delirium because they're not eating, drinking anymore. They're not getting the oxygen and nutrients to the brain. So delirium just means your client has sudden confusion. They don't know where they are. They forget your name. They don't know what they're doing there. And sometimes they can go in and out of delirium, right? They can have a delirious episode and then come back and be okay, and then have another delirious episode, that type of thing. So that's another very common thing that occurs as they're approaching death as well. And other common signs and symptoms, irregular breathing again is another one, congestive breathing, irregular breathing. They start to get the mucus build up in their lungs, causing breathing difficulties. These are all very common signs and symptoms in the last hours of life. So, if you're taking care of someone after death, then there may be things you want to keep in mind with the body. Usually, the funeral home is going to come to pick up the body. That should be prearranged a few weeks at least before they think death will occur. And your loved one or client should be on their back. Their eyes should be closed. If we're talking about appropriate care at the end of life, their eyelids should be closed, their jaw should be closed. So if they're open, you can put something on their eyelids to keep them closed. You can put a towel under their chin to keep their mouth closed. And at the when death occurs, they might have a release, so you are going to have to clean them up, put clean clothes on them, that type of thing, and make them look presentable to family members, or make them or get them ready for when the funeral home arrives to pick up the body. The funeral home has kind of their own procedure once they get there, and they kind of preserve the body with different types of fluid and get the body ready for the funeral. But you're kind of there to get them in respectable looking condition, of course, keeping their dignity even after death, right? You always want to keep their dignity after death by respecting the body, cleaning the body, presentable body for when the funeral home arrives to pick up the body. Okay, folks. And those are some of the important facts and figures I wanted to get out for you tonight. And if you have any questions, you can hit me up in the chat box now. And of course, I also wanted to mention my website. I do have a website called caregiverjoe.com. Caregiverjoe.com. I have a couple other workshops on there. One of them related to this is life after life. What is the evidence for life after life? So I talk about religious beliefs, personal beliefs. I talk about children that are talking about past lives. I go through some of the evidence for and against life after life. Obviously, that's one of the big questions of the universe, right? Is there life after life? What is the evidence for that? And then how can we put all of that evidence together, pro and con, to kind of help people make their own decisions around what their beliefs are for life after life? It's kind of good to gather evidence to see how much evidence there is for life after life. And to put that together in a workshop is kind of interesting, bringing that information together for you guys. So, website again, caregiverjoe.com. YouTube, I am at caregiverjoe.com. YouTube at caregiverjoe.com. And if you want to send me an email, it's info at caregiverjoe.com. Info at caregiverjoe.com. Very good. I think that's it for tonight. Thank you for coming out. I appreciate it. And I'm going to do many more live streams. You guys keep the subscribe button on, and you'll see that I'll be doing more of these in the future. Thanks, guys. Talk to you soon. Bye bye.